A production fee for your Hometown Health Connection was made by Buffalo Healthy Living Magazine and its sponsors. What is a gastroenterologist? Well, it's a doctor that handles gastrointestinal concerns like your digestion. And of course, helping you with any problem you might have with your esophagus, stomach, small intestine, colon, rectum, pancreas, gallbladder, liver, and colorectal cancer. Colorectal cancer is the third most common cancer diagnosed in both men and women in the U.S. The American Cancer Society estimates for 2022 to predict over 107,000 new cases of colon cancer and 45,000 new cases of rectal cancer. Now, those two cancers are being found earlier when they are easier to treat, with more than 1.5 million survivors of colorectal cancer in the U.S. Or perhaps you might suffer from heartburn, indigestion, dyspepsia, bloating, and constipation. Now, is that a sign of something more? And what do those symptoms really mean? How do you treat those GI conditions? Your gastroenterologist will know. And what about irritable bowel syndrome? According to the College of American Gastroenterology, 10 to 15% of the adult population suffers from IBS symptoms, yet only 5 to 7% of adults have been diagnosed with the disease. Is irritable bowel syndrome the most common disease diagnosed by gastroenterologists? On this edition of your Hometown Health Connection, you're going to meet a very prominent Western New York gastroenterologist. He's going to answer these questions and more with information that might just save your life or the life of a loved one right here on this edition of your Hometown Health Connection. I'm John DeSciullo in for Kate Glazier, and welcome to the program. Today, you're going to meet Dr. Ahmad Kadhim, a gastroenterologist, a general physician PC who is skilled in both internal medicine and gastroenterology. Dr. Kadhim completed his fellowship in gastroenterology and motility at University of Toronto and his residency in internal medicine at Wayne State University in Detroit, Michigan. He's a member of the American College of Gastroenterology, the Canadian Association of Gastroenterology, and the American College of Physicians. Dr. Kadhim, welcome to the show.
Thanks for having me.
You're welcome. So explain the role of what a gastroenterologist does.
So a gastroenterologist is a physician who is an expert in the field of the gastrointestinal system. So typically we're fellowship trained and board certified to treat and diagnose gastrointestinal disorders.
And all of those symptoms that sometimes come with a gastrointestinal disorder, you treat them. What are some of those symptoms?
So looking at the upper digestive system, there are symptoms such as gastroesophageal reflux disease, where you have too much acid refluxing back, causing difficulty in swallowing, heartburn, that burning sensation you get in your chest. Sometimes you have abdominal pain or the complex of what we call dyspepsia, where you have nausea, abdominal pain. And then moving into the lower digestive system, there are things that have to do with the bowel movements, bowel habits, diarrhea, constipation, inflammatory bowel disease, Crohn's disease, ulcerative colitis. And then there's another dimension that we deal with that has to do with pancreatic disorders, liver disorders, and that sort of thing.
So a lot of different levels there. I know that with upper GI, the treatment for an upper GI issue, much different than a lower GI issue. So I guess, is there a hierarchy of concern for upper GI versus lower GI?
I mean, that is correct to a certain extent, but they're completely different systems. In the upper digestive system, we deal mostly with the esophagus, stomach, and part of the small intestine, versus in the lower digestive system, we deal mainly with the colon and colorectal disorders.
We'll talk a little bit about that in our next segment too, but let's move on, because so many different things are in this umbrella of gastroenterology. And GERD, what is that, G-E-R-D?
So it's a disorder that stands for gastroesophageal reflux disease. And essentially what happens is you have reflux of acid upwards. As we all know, acid is a very good thing that helps us digest food, absorb nutrients and vitamins, but sometimes for multiple reasons, the acid can reflux back into the esophagus, and it can cause burning, chest discomfort, difficulty swallowing. It can also cause bad things such as asthma, coughing, and teeth decay.
So it could lead to other things down the line.
Yes, it can.
Does it get any different with age? You know, if somebody has an issue when they're younger and then they get a little older, I've suffered from some of that, where you have that uncomfortable feeling Is it more prevalent in people who get a little bit older, gastrointestinal concerns?
I would have to agree with that, yes. What happens is there are muscles that control the flow of acid. So there's a lower esophageal sphincter, and there's a theory that with age, just like any muscle in our body, it kind of becomes a little laxed. It doesn't protect the esophagus completely from the acid. So some of the acid, as a result, will reflux back up.
So whether it's GERD, acid reflux, any of the other conditions you mentioned, how do you treat once you get a symptom and you meet a patient? How do you offer a treatment plan? I'm sure everything's different for each patient, but give us kind of an overview of what that might be.
That's exactly right. I mean, we look at each patient individually, so as an individual, but the cornerstone for me is prevention. So if we don't have to give you medications, we can talk about your lifestyle, your eating habits, and just kind of going through those and figuring out a plan to avoid the disorder is very beneficial to the patients.
So what you eat could obviously play a role. You know, for me, I can't eat onions. Just can't. I can eat them cooked, not raw. Some people can't eat peppers. Some people have, I'm sure you've heard every story of the book. But what you eat is very much a part of how your body is going to react, because if, you know, bad stuff goes in, bad stuff's going to happen, right?
Absolutely. I tell my patients the cornerstone of digestive health is diet, diet, diet. So we have to be mindful of what we put in our body. And it all depends on the disorder. So if you have gastroesophageal reflux disease, we minimize foods that promote acid production, and a lot of patients benefit from that.
Yeah. Let's move on to something that we hear about, and I know you've said to me you've done lectures on this, irritable bowel syndrome. And how does it find its way into a person's life? Is it because of what they eat? Is it something hereditary? What causes it? What is it?
It's a very common disorder in the gastroenterology practice. It's multidimensional. So what it means is, so patients typically have symptoms. It could be bloating, it could be abdominal pain, it could be diarrhea, it could be constipation. And what causes it is multifactorial. So diet is a big component. Nerves, anxiety, and health and mental health control is another component. Genetics is another component. Stress and anxiety. Also, bowel habits. If someone doesn't have regular bowel habits, that can have a domino effect upstream and causing excessive bloating, gas production, right, and that kind of thing.
And constipation, which is, I would think, common. Although I will, you know, in full disclosure, I know some young people that have some issues with that too. I would think that would be something that you would look at maybe as an irritable bowel syndrome. Is that part of it? How would constipation fit into that?
So it can be, it certainly can be, but the most important thing about irritable bowel syndrome is we call it a diagnosis of exclusion. We have to rule out more serious things. Are there lesions in the colon? Is there inflammation? Is there colitis? So once we rule out all of these disorders by the various tests that we do, then we will focus on the treatment of irritable bowel syndrome, and constipation definitely fits into it.
What's the treatment?
So again, we look at all these different parameters and try to address them individually. So in terms of diet, there is a diet called the low FODMAP diet I encourage my patients to follow. I try to find their eating pattern. If they're lactose intolerant, we introduce lactate type of dairy products. If they have anxiety and nerve issues, that can definitely impact their bowel health. So we try to treat them with that as well. And then the motility aspect of the digestive tract, if they're too fast in terms of diarrhea, we tend to slow them down. If they're too slow and they have constipation, we tend to speed them up. And then finally, the abdominal pain we can treat with various antispasm medications.
And motility is the movement through the body. I just learned that today,
exactly,
having to meet you.
Yes.
Is it something that's curable, or is it just something you just kind of live with and treat along the way?
I think if we address all of those pillars with irritable bowel syndrome, I'm not going to say 100% improvement, but in my experience and my patients, if they follow this diligent plan, I would say 70-75% of patients feel much better when they come back.
You said something interesting a couple of times, stress and anxiety. Now, who doesn't have stress and anxiety in their life? You know, you have young children. I would imagine there's a lot of sleepless nights. You have, how old are your children?
2 and 4.
Yeah, so, you know, there's some anxiety there, and good anxiety, but,
yes.
But people have different ways of processing it. And I do know that some people, obviously, they internalize it, and that results in some of these issues. Am I correct?
Yeah, we have a saying in the neurogastroenterology world that there is more nerves in our gut than our brain. And I often tell my patients, if your nerves are active, that's going to have a negative impact on your digestive health and on your symptoms. So controlling the anxiety, controlling the stress will have a very positive effect on the bowel health.
Yeah, and your mental health too, because you're going to channel that stress. Let's talk about irritable bowel disease. What is the difference between what we just talked about earlier and irritable bowel disease?
So I think you're referring to inflammatory bowel disease.
I'm sorry, yes.
So inflammatory bowel disease, there's an actual inflammation in the colon. And the two major subsets are ulcerative colitis and Crohn's disease, where there is inflammation of the colon. And this can lead to bloody stools, abdominal pain, weight loss, and really severe inflammation in some cases.
We talked about treatments or how you're able to manage it with food. Is there any sort of medication that goes with any of this that would, we hear about over-the-counter medication for stomach issues, but is there anything that you would prescribe in a different measure for some of these conditions we just talked about?
So definitely the diet is number one. In terms of medications, depends on the condition and depends on the severity of the condition. So we look at the patient, if they're on the mild end of the spectrum, obviously we give them mild medication over the counter. So probiotics, things are like simethicone or Gas X to help relief with the gas. Things like to help with the abdominal spasms. But if the inflammation and the disease is severe, then there are other potent medications that we can offer. So it really depends on the condition.
Right. So if somebody has some stomach issues and they keep popping those antacids continually, is that a sign that maybe they should come in to see you for something that might be more serious?
Yeah, exactly. So if they're taking the over-counter medications and they're not seeing any benefit from it and the symptoms persist, then they should definitely seek an expert opinion.
So everything that we just talked about, we talked about certain ways that these things come upon you, and we talked about the treatments. Is it something you have to manage as you go through your life? And when you see a patient for follow-up treatment, do you monitor their diet, monitor their exercise, monitor their stress?
Yeah, so we have goals. So when we meet with the patient, we tell them, your goal is to follow this following diet for the next X number of months. So in my case, I usually use 3 months as an example, and try the following medication. And as they go along, they have to write a log, a food log or a symptom log, to see if there is an improvement. And that way we can discuss in the follow-up visit to see if there is any progress.
Is it more prevalent with men or women to have gastro issues?
It depends on the disorder. So some disorders are more prevalent in men. So like gastroesophageal reflux disease or GERD is in typical 50s, slightly obese, history of slight alcohol consumption and smoking males, or white males, Caucasian males. Irritable bowel syndrome we see more common in females. So it really depends on the disorder.
Yeah. How about young people? Is it becoming more prevalent? Because I have to say the diets for all of us could all be better. Do you see any of this happening at a younger age?
Absolutely. So two things that we see. One is there's a new entity, well, it's relatively new, called eosinophilic esophagitis. We see it a lot in young people who have history of asthma, who have rashes. It's actually a food allergy. So anytime they consume something, they would feel chest tightness, chest discomfort, and it can mimic gastroesophageal reflux disease. And this has to do, it's because of certain food allergies that we have to investigate. And then the other one is celiac disease. We're picking it up more frequently in younger individuals.
Well, we're going to talk more about the food allergies and celiac disease when we continue our conversation with Dr. Kadhim right here on your Hometown Health Connection. Now we're going to continue our conversation with Dr. Kadhim, but if you want to get information on where you can find Dr. Kadhim, you want to write down this phone number and this website. You ready? You got a pen and paper? Here it comes. The important phone number to call is area code 716-626-2644, and the website is gppconline.com. Now you can make an appointment with Dr. Kadhim at one of 2 locations in Western New York with General Physician PC at Sheridan Drive in Williamsville, at 5225 Sheridan, or 5844 Southwestern Boulevard in Hamburg. Now, if you have a problem, don't put it off. Proper diagnosis will make you better. We'll be right back with more. Buffalo Healthy Living Magazine is a free, full-color magazine distributed throughout Western New York. Now, more than ever, as we all want our families and friends to be safe and well, Buffalo Healthy Living magazine is devoted to health, fitness, and nutrition for people of all ages. It's a great read and also has great recipes. Pick up Buffalo Healthy Living magazine all over our hometown or go online anytime at buffalohealthyliving.com. Welcome back to your Hometown Health Connection. John DeSciullo in for Kate Glazier, and we are continuing our conversation with Dr. Ahmad Kadhim, and your gastroenterologist with general physician PC. You said something earlier before we were recording the show. There are more nerves in your stomach than there are in your brain?
That's correct. In your digestive system, yes. There are a slew of nerve complexes, more than your brain, actually. So that it can explain a lot of the sensitivities and the issues that we can have.
You mentioned before the break celiac disease. What is celiac disease? So
celiac disease is a disorder where you're intolerant to gluten, and gluten is a food component that is found in pretty much everything, primarily wheat, rye, and some oats, and barley as well. So what happens is when we consume gluten, we trigger an immune response in the digestive and in the small intestine, and that can cause symptoms such as bloating, abdominal pain, nausea, diarrhea, constipation. It can also cause extra intestinal manifestations such as rashes in your skin. Sometimes there's a mental kind of, we call it a psychosis or a disorder that's also associated with it. So it can affect multiple aspects of your body.
You know, we've all seen sections now in the supermarket, gluten-free. It's become I would say quite common, but I would say it's quite common, wouldn't you say?
Yes, it is.
What you see. And yet, not that many years ago, it was difficult to find products that were gluten-free. What took us so long to get to this point to realize gluten might be the enemy of our body a little bit?
Actually, to take it a step further, we've noticed a trend where individuals have similar symptoms to celiac disease. And when we test them, they don't have celiac disease. So we said, well, how about you go on a gluten-free diet trial? And a lot of them would actually improve. And so this came up with the new entity called gluten sensitivity syndrome. It's not really celiac disease per se, but it's sensitivity to gluten. And if patients steer clear from gluten, they actually feel better.
And some of us can have it and not have any concern whatsoever.
Correct.
But you touched on something in the last segment about food allergies. Would that be confused for gastroenterological issues, or you're just allergic to something?
So yeah, I mean, food allergies or intolerances can definitely exacerbate your gastrointestinal disorders. Absolutely.
So how would we manage celiac disease besides eating gluten-free, and is there a medication that goes with that?
So the cornerstone of management of celiac disease is actually prevention. So I would tell patients, as you alluded to earlier, go on a gluten-free diet for a period of time. There are some medications coming down the pipeline, but they're not ready for prime time yet. But I think within the next maybe 1 to 2 years, they should be available.
March is recognized as Colorectal Cancer Month. It's an important topic no matter what month of the year, not just March. And we've done some programs on colorectal cancer, and I know that's an area of your expertise as well. Why is it becoming so prevalent?
You know, we're noticing lately overall it has decreased with elderly individuals, and we are happy because of the screening colonoscopies. But lately we're picking it up more in younger individuals.
People, yeah. And
if you, I'm sure you heard the news that they lowered the screening guidelines from 50 years to 45 years. So it's happening more frequently in younger individuals.
So with that, why do you think it's happening in younger individuals? Is it because of the diet that we are having?
You know, no one really knows for sure. There are theories out there. So definitely diets, so foods that are high in white meats, a lot of alcohol consumption, a lot of smoking. There's also environmental factors, pollution. There's definitely also genetics that we can also kind of correlate with rising cases of colorectal cancer. So no one really knows for sure, but those are theories that we look at.
So I'm going to now admit on television, and you're going to hate me for this, and I'm going to get the look. I just turned 60. You know what I haven't had, Doc? I haven't had a colonoscopy. That's not a good thing, is it?
It's recommended at age 50 or 45. And, there might be, reasons for patients to be reluctant to having it, but I think overall the benefit outweighs the risk for sure.
So why do idiots like me put it off? Why should we not do that? Why should we embrace this and go and get it done?
I mean, if when I interact with patients, it is a procedure. You have to take some time off work. You have to do a bowel prep that not many people are excited about. So those are valid reasons. I mean, my father refuses to have it done, even though my uncle, his brother, had colon cancer, and I tried to convince him, and some individuals just don't want to undergo that procedure.
But it's not a difficult procedure, and it's not, I guess, when you look at it overall, something you should put off because of the things that it would find. What are the symptoms of colon cancer that a colonoscopy would find? We may not know until we have the colonoscopy.
That's exactly right. It may be too late. And that's why it's hard to encourage individuals to undergo a procedure where they feel fine. They really have to understand it's for the future. So if they want to be around next with their families,
right,
and if they want to live a long time, they have to undergo it.
And the treatment, well, I shouldn't say the treatment, the prep is what I was getting at, is what people tend to talk about the most. So for one day, you're going to have the prep, and you got to, what is the prep all about?
So it has evolved. So the prep is basically is an osmotic solution that you consume, and what it does is it cleans the small intestine and the colon. So that way, when the colonoscope is done, we can actually examine the tissue and look for abnormalities and remove smaller polyps. That's the whole idea behind the prep.
Yeah. And the prep gets you ready, and then you go in for the colonoscopy, which is really a very short procedure.
Yeah, exactly. So it takes about anywhere from 10 minutes to 15 minutes,
yeah,
and then you're done.
And mildly sedated, so.
Yeah, there's different types of sedations out there. There is typically anesthesiologist available, and they would get an IV line and give you a small dose, and you would doze off for 10 minutes or so, and then you wake up in the recovery room.
And most times, things are clean. What if something is seen? What's the next step?
So that's what makes a colonoscopy so effective, is that we can pick up small lesions before they turn into cancer and remove them. And that's why we encourage individuals to undergo those tests.
Well, I know, that actor that passed away a few years ago, Chadwick Boseman, really called attention to it. Sometimes it takes prominent people to have a condition and then brings it to light. I'm sure he saved a lot of lives by just telling the world what he had before he passed. And let's talk about some other ways that you can look at that. Like there's Cologuard over the counter. How effective are they? And how would you suggest somebody interact with a product like that?
Yeah, so there are multiple colon cancer screening tools that have been suggested by the USPSTF, which is the United States Preventative Task Force. Obviously, the gold standard is a colonoscopy, because
right,
you're able to, you're actually in the colon, you see the lesion, you remove it, and then you move on. There are other tests. So Cologuard is the home kit.
And there are probably other home kits. We're not here to promote that particular
right,
brand, but that's the one we see most of.
Right, so it's a home kit, so it has the advantages of, you don't have to do a bowel prep, and then you just kind of do it at your home and you send it off. Obviously, it can have a lot of false positives and false negatives. It's not recommended for individuals with family history of colon cancer or polyps, or individuals who have symptoms. So it has to be an average individual. There are things such as a CT colonography, which kind of made the news a few years back.
What is that?
So what it is you drink a bowel prep, but instead of having a colonoscopy, you have a CT scan. So you look at the colon virtually. You're not inside the colon, and then that way you detect lesions. It's time consuming, and sometimes if you find a lesion, you kind of have to follow it up with a colonoscopy. But it's an effective option that's available. Also, a while back, we used to do the guaiac cards or the FIT cards, where you actually put a stool sample on the card to see if the color changes. Those are available tools, but I believe the colonoscopy is the gold standard.
So lowering the age to 45 now is the sort of the standard practice, and then moving forward. Once you have a colonoscopy, do you need to go back and do it again? And if you do, what's the time frame?
Yeah, so that really depends. If you don't have any family history or risk factors and your colonoscopy is normal, then you're covered for 10 years. If we remove a polyp, depending on the size of the polyp, the number of the polyp, and the location of the polyp, it could be sooner. It could be 5 years, it could be 3 years, but the standard is if your colonoscopy is normal and there is no family history, you're good for 10 years.
When someone has blood in the stool, is that a warning sign that they should, again, come to see you?
Yes, of course. So the alarm symptoms that we always worry about is blood in the stool, abnormal weight loss, and things such as difficulty swallowing, decreased appetite. So blood in the stool should definitely be investigated, yes.
You mentioned earlier that COVID has had some impact in, we hear about it in breathing, but you've mentioned it even in gastrointestinal issues, some of the long-term effects. It was interesting to hear that.
Yeah, it affected, COVID had an effect on the gastrointestinal symptoms as well, and it caused, to a lesser degree, an inflammatory process. And we find that patients, after they recover from the COVID, they continue to have nausea, bloating, diarrhea, change in bowel habits. I think part of it has to do with the regeneration of the digestive system, and our best hope is that this hopefully should go away 3 to 6 months after the infection.
Yeah.
But we don't know for sure.
We've talked about a lot of things that some people may find uncomfortable to talk about, even with their family. They shouldn't be afraid to talk about it with friends, family, and particularly a medical expert like you or their general physician so that they can get the help that they need. Why are people so afraid to talk about their bowel movements and things that might be uncomfortable to talk about? Even though we're talking about it on TV, we're hoping to help people. Why do people have that stigma?
Yeah, you know, they shouldn't. They really shouldn't, because, you know, you need to think about your health and your family and sticking around for the loved ones. I don't know why there's a stigma around that. Maybe a little shy to discuss, you know, I mean, not everybody likes to talk about their bowel habits and bowel symptoms, but I encourage everybody to seek help. You know, that's what we do. We sit down and listen to you and try to help you out, so.
When you have a consultation with a patient, what do you discuss?
So, you know, we go over multiple things depending on the reason for the visit, but definitely, you know, the dietary history, the family history, the symptoms, how they range, and I'll try to get an idea of how long has been going on, and hopefully pinpoint an actual cause and try and address it.
So we need to watch our diets, we need to keep our stress in check, we need to get our colonoscopies, and we need to come to see the gastroenterologist whenever there's a sign that something might not work.
Well said. That's exactly it.
All right. Thanks for joining us on your Hometown Health Connection.
My pleasure.
Dr. Ahmad Kadhim. Now I'm going to give you some information on where you can connect so you can make that call and save your life or the life of a loved one. We thank Dr. Kadhim for joining us here on your Hometown Health Connection and offering some important information that maybe we didn't hear about. And you know what? I will promise to get that colonoscopy. But if you want to make an appointment to see Dr. Kadhim, here's the information that you need. You can connect with him at 5225 Sheridan Drive in Williamsville. You can call for an appointment at area code 716-626-2644, or the other location that he practices out of at 5844 Southwestern Boulevard in Hamburg, both general physician PC areas. And the website is gppconline.com. And again, that phone number is 716-626-2644. And don't wait, like we said, if you need a diagnosis, if you need to find out what's wrong with you, you should call and make that appointment. I'm John DeSciullo. Thanks for watching your Hometown Health Connection. Be safe and be well. A production fee for the preceding presentation of Your Hometown Health Connection was made by Buffalo Healthy Living Magazine and its sponsors.